All right, guys, so I'm picking up with uterine rupture. We talked about who is at risk today. This is why women who've had previous C-sections, we counsel that there is a risk for uterine rupture. And often, if they're well monitored in labor and they've had just one low transverse incision, we will do a trial of labor called a TOLAC, trial of labor after cesarean. However, once a patient has had multiple C-sections, we start doing repeat C-sections. The other patient who would always need a C-section is somebody who's had a classical uterine incision. Because her incision, guys, from a classical would go from up here to down here, right? She's at huge risk for a rupture because we know where her incision is in the upper portion of the fundus, the uterus, that this active part that's contracting, if the scar is in that active portion, it's more likely to rupture. So as the nurse, how can you assess that this is occurring? Well, you could lose the fetal heart rate tones because that baby can either be partially out of the uterus in the abdominal cavity or completely out of the uterus. And the woman will have a ripping, burning abdominal sensation from the rupture occurring. She needs a stat C-section, guys. This is showing a picture again of what's happening during a rupture. Again, your patient with a classical incision is most at risk. This is showing absence of fetal heart tones. Our next concept is something that normally happens, guys, as the placenta is delivering or after the placenta has delivered. It's the uterus inverting, so folding in on itself and coming out of the vagina. The uterus has to be placed back immediately. So the provider here is demonstrated as having its fist in the uterus to keep it in place. What we use to keep the uterus in place as opposed to the provider's fist is getting a balloon and blowing up this balloon as the uterus is reintroduced into the pelvic cavity. Rare complication, but can occur. Also rare complication, thankfully, is an amniotic fluid embolism, guys. This is a piece of amniotic fluid or fetal hair or fetal skin getting into the maternal system. So again, remember those cells don't mix. But in an event like an amniotic fluid embolism, the woman has exposure to the amniotic fluid or skin or hair in her blood system, and it goes straight into her lungs, guys, and puts her into acute respiratory failure. This woman gets sick quickly. She's somebody who's having a vaginal birth or sitting on the OR table for her section, talking to you, and then the next minute she's not. This again is an acute pathology because once that piece of fluid or hair or skin reaches the maternal vascular system and enters her lungs, she's done from this. So she's going to get hypotensive, she's going to go into shock, loss of consciousness, disseminated intravascular coagulopathy, right? She's going to be bleeding out essentially. And often this leads to maternal death, and the only way to truly diagnose it, guys, is through an autopsy. We find that amniotic fluid embolus in mom's lungs. But again, this presentation goes from your patient totally fine to sick right there in front of you. The next thing that I wanted to cover was trauma, and just really quickly thinking about a patient who's been in trauma, car accident, been in any sort of traumatic environment is at risk for placental abruption, right? Because of that, the trauma that occurred. So you want to remember your signs of abruption, which we covered today, and her delivery course would be a stat section, right, if she's abrupting. So we hope that our outcome is good. I know today we covered a lot of complications and there's a lot of things to fill out on your study guide and all, but we hope the outcome is a normal, healthy birth, but we need to be prepared if it's not, of all the things that can occur. So let me know if there's questions, and that's it for this recording, guys.